Welcome to the debate. Today, we are challenging a medical ritual that has remained, well, largely unchanged for a century. If you ask a diabetic to describe their daily therapy, they'll likely talk about the smell of phenolic preservatives, that distinct Band-Aid scent of liquid insulin. And of course, the bruising from just thousands of needle punctures.
Right. It's a life measured in millimeters of steel.
Exactly. But since 2014, there has been a sort of ghost in the machine, and that is Afrezza. It's an inhaled, rapid-acting human insulin. And the central question we are debating today is really one of biological trade-offs. We want to ask, is Afrezza the ultimate liberation for patients who are just pinned to a regimen of injections, or is it a pulmonary hazard wrapped in the guise of convenience?
It is a question that requires us to look past the cool factor of the device and stare directly at the physiology. Because on paper, inhaling insulin sounds like the future we were all promised. But when you examine the FDA's approved labeling, specifically the boxed warning regarding acute bronchospasm, the future looks potentially dangerous.
I represent the position that this is a vital, innovative option. Afrezza provides unique pharmacokinetic benefits and a massive quality of life improvement for the right patient.
And my argument is that the lungs were evolved for gas exchange, oxygen in, carbon dioxide out. Using them as a port of entry for a systemic growth hormone creates a risk profile that I believe is vastly underestimated. We are essentially trading a needle in the skin for a potential spasm in the airways.
I understand that caution, I really do, and we absolutely need to dissect this safety profile because lung spasm is it's a terrifying phrase. But I want to start by framing what this technology actually is. There's this misconception that it's just crushed up insulin pills, right?
Mm-hmm.
It's much more sophisticated than that. Afrezza uses a proprietary carrier called Technosphere technology. These are microspheres of fumarate dicotrypyrazine. It sounds incredibly complex, but the mechanism is elegant. When you inhale them, they reach the deep lung, the alveoli, and they dissolve immediately upon contact with the neutral pH of the lung surface.
Yeah, the chemistry is clever. I'll give you that.
Right, and this isn't just about avoiding pain. It's about pharmacokinetics. It mimics the body's natural release of insulin better than any liquid injection ever has. For the millions of diabetics suffering from needle fatigue or legitimate needle phobias, this isn't just a convenience, it is a bridge to actual compliance.
I appreciate the elegance of the chemistry. Technosphere is certainly a clever delivery vehicle, but compliance at the cost of lung function is a pyrrhiclictory. Innovation has to maintain the safety floor, and here the floor has cracks. The FDA label is explicit. Afrezza is contraindicated, strictly forbidden, for patients with chronic lung disease.
Which is a known boundary.
But it means if you have asthma or COPD, this drug is completely off the table. This isn't a proceed with caution warning, it is a hard stop. The clinical data showed that when patients with asthma tried this, acute bronchospasm, a sudden violent tightening of the airways, occurred. So my position is that for a vast number of patients, the needle is actually the superior, safer, and much more reliable delivery method. Furthermore, let's not forget, for type 1 diabetics, Afrezza is not a cure-all. They still need long-acting basal insulin.
Yes.
The needle doesn't disappear, it just visits less often.
Well, that is a vital distinction regarding type 1 diabetes. This is a mealtime replacement, not a basal replacement. You still need that background insulin. However, reducing the daily injection burden from, say, 5 or 6 shots down to 1 or 2, that is a profound shift in quality of life. My position is that for the needle-naive patient, or those dealing with the stigma of injecting in public, Afrezza offers a discrete, color-coded cartridge system. You have blue for 4 units, green for 8. It normalizes their life, and scientifically, it works. In type 2 diabetes trials, it provided statistically significant HbA1c reduction compared to placebo. We are looking at a tool that can bring people back into range who have otherwise just given up on therapy entirely.
It works is the baseline expectation for any approved drug, though. If it didn't lower blood sugar, we wouldn't be sitting here talking about it. The question is, at what cost? We need to open the black box immediately. It is the most serious warning the FDA issues. In a study cited in Section 5.1 of the prescribing information specifically involving asthma patients, bronchoconstriction and wheezing were reported in 29% of subjects.
Yes, but
That is nearly 1 in 3 people essentially having an asthma attack because of their diabetes medicine. In that same study, researchers observed a mean decline in FEV1, that's forced expiratory volume, of 400 milliliters just 15 minutes after dosing. To put that in perspective for the listener, losing 400 milliliters of lung capacity in 15 minutes is like suddenly trying to breathe while someone is sitting on your chest. That is a massive physiological shock.
Okay, but I think we need to be very precise about which population we are scaring here. You are citing data for patients with asthma.
Because the data is striking.
It is, but the label explicitly states Afrezza is contraindicated for those patients. The system is designed with a mandatory screening barrier. Section 2.5 of the label dictates that before a patient ever inhales their first dose, they must undergo a detailed medical history, a physical exam, and spermometry testing to rule out lung disease. If the protocol is followed, the 1 in 3 scenario you described simply doesn't happen because those patients are screened out. We are debating the safety for healthy lungs here, not compromised ones.
That assumes a perfect clinical world where screening never fails and patients never develop undiagnosed issues. But even if we grant you the healthy lung cohort, the signal persists. The data shows a decline in pulmonary function over time, even in patients without lung disease. There was a distinct difference, about a 40 milliliter greater decline in FEV1 in the Afrezza group compared to the control group over the first 3 months. Now, 40 milliliters sounds small compared to 400, but it is a measurable reduction in organ function caused directly by the drug. You are coating the delicate alveolar sacs in powder 3 times a day. We have to ask, is that sustainable for 20 or 30 years?
That 40 milliliter decline is noted in the data, absolutely. But context is crucial. The studies indicated that this decline occurred early in the first 3 months, and then it plateaued. It did not continue to degrade over the 2-year observation period. It's a non-progressive change. Now, we have to weigh that stable minor shift against the devastating risks of uncontrolled hyperglycemia. We know that high blood sugar leads to blindness, amputation, and kidney failure. If a patient is skipping injections because of pain or social anxiety, the risk of losing a foot is far higher than the risk posed by that 40 milliliter plateau. For that patient, the lung risk is theoretical. The diabetes risk is immediate and catastrophic.
I contend that the trade-off isn't that binary. It's not take this or lose a foot. There are plenty of other options. But let's shift to the speed argument, because this is often the main selling point. Advocates claim it's ultra-rapid, implying it fixes high blood sugar instantly.
It is ultra-rapid, and I firmly stand by that. The pharmacokinetic profiles, how the drug moves through the body, show that maximum serum insulin concentration is reached in 12 to 15 minutes.
Right, concentration.
Exactly. Compare that to subcutaneous insulin Lispro or Aspart, which can take 45 to 60 minutes to peak. Afrezza mimics the body's natural first-phase insulin response to food ingestion. When you eat a bagel, your pancreas doesn't wait an hour to work. Neither should your insulin. This speed is what allows users to dose right when they eat, rather than guessing 20 minutes beforehand.
Well, I think you are conflating kinetics with dynamics there, and this is a critical technical distinction. Kinetics is how fast it shows up in the blood. Dynamics is how fast it actually lowers the sugar. Section 12.2 of the prescribing information is very clear on this. Despite that lightning-fast absorption, the onset of action, the actual glucose lowering, is comparable to insulin Lispro, not significantly faster. The peak glucose infusion rate occurred around 53 minutes. So you have a drug that slams into the bloodstream violently fast, potentially irritating the lungs, but the metabolic result is roughly the same as the injection.
Roughly the same onset, yes.
And regarding efficacy, in the type 1 trials, we have to address the non-inferiority nuance. Afrezza met the margin, yes, but it actually provided less HbA1c reduction than insulin Aspart. The difference was statistically significant. It was technically good enough, but it was not better.
It provided less reduction, but it remains within the 0.4% margin required by the FDA. It effectively controlled blood sugar. But the benefit isn't just the onset, it's the offset. The serum insulin concentrations declined to baseline by approximately 180 minutes. Subcutaneous analogs often hang around for 4 or 5 hours. That tail is dangerous. It causes hypoglycemia, low blood sugar long after the meal is over. Or it leads to stacking, where a patient takes a second dose thinking the first didn't work. Afrezza enters fast, does its job, and leaves. That distinct profile drastically reduces the anxiety of late-day lows. That snappy offset is where the lifestyle liberation really happens.
But let's talk about the immediate sensation of that entry. We cannot ignore the cough. It is the elephant in the room. In the adverse reaction data, cough was reported by 27% of patients on Afrezza versus only 5.2% in controls. That is more than a quarter of the user base. It was the #1 reason for discontinuation. Picture this. You are at a business lunch. You want to be discreet, so you use your inhaler. Immediately, you suffer a dry reflex cough. You have just drawn more attention to yourself than if you had quietly injected a pen under the table. That isn't seamless lifestyle integration. That is a social and physical irritant.
Look, I acknowledge the cough is real. It's a reflex to the powder hitting the throat or upper airway. However, clinical experience shows that for many, this is transient. It diminishes as the technique improves and the throat gets used to the sensation, much like a coffee drinker getting used to hot liquid or a runner adjusting to cold air. And I would argue that a dry cough is a symptom many are willing to tolerate to avoid the very real physical trauma of lipohypertrophy. You know, those hard lumps that form under the skin from repeated injections. It's a choice between a tickle in the throat or scarred tissue in the abdomen.
It's more than a tickle for some, it's a spasm. But let's move to the device itself. You called it discreet and simple, but I find the operational requirements quite fragile. The Genefear concept sounds high-tech, but the instructions for use reveal a high-friction user experience that really contradicts the easy narrative.
I disagree completely. It's a whistle-sized inhaler. You take a cartridge, you load it, you snap it shut. That snap punctures the blister. You exhale, put it in your mouth, and breathe in. It's incredibly intuitive. It fits right in the palm of your hand.
It sounds intuitive until you read the fine print regarding temperature. The cartridges must be at room temperature for 10 minutes before use. You cannot just take a blister card out of the fridge and inhale. Cold powder doesn't atomize correctly. You get underdosing. So now the patient has to plan their hunger 10 minutes in advance, or they have to carry the blisters around all day. And once you open the foil strip, you have to use it within 3 days. The inhaler itself must be discarded every 15 days. Compare that to a flex pen that can stay in your pocket for a month. Afrezza requires a regimen of temperature control, orientation discipline, don't tip it upside down or you lose the powder, and expiration tracking. It introduces cognitive load to a disease that is already mentally exhausting.
Those are fair operational constraints. But let's look at the reality of the alternative. Diabetics are already carrying vials, syringes, alcohol swabs, and, crucially, a shops container. You can't just throw a needle in a public trash can. With Afrezza, the used cartridge is household waste. The inhaler is household waste. The freedom of not being tethered to a biohazard disposal system is a massive logistical victory. And regarding the 10-minute rule, most diabetics keep their current in-use insulin at room temperature anyway. Afrezza is stable at room temperature for 10 days in unopened strips or 3 days opened. That covers a weekend trip or a work week easily. It requires a routine, yes, but so does boiling water. It becomes second nature.
Let's escalate this from inconvenience to severe pathology. We touched on the lungs earlier, but we really need to discuss section 5.5, lung cancer. In the clinical trials, 2 cases of lung cancer were observed in the Afrezza group. There were 0 in the comparator group. Post-trial, 2 more cases appeared in non-smokers.
That is a terrifying statistic without context. The label clearly states that in the 2 trial cases, the patients had a history of heavy tobacco use. We know smoking is the primary driver of lung cancer. The data is currently insufficient to determine causality between the insulin powder and the cancer. However, I agree with the label's guidance. Afrezza should not be used in patients with active lung cancer. That is simply prudent medicine. But to suggest the drug causes cancer based on 2 smokers in a large trial is a statistical leap that the data simply doesn't support.
It's a signal, though. In drug safety, we look for signals.
And when you combine that with the diabetic ketoacidosis data, or DKA, the risk profile thickens. In the type 1 trials, DKA was significantly more common in the Afrezza group, 0.43% versus 0.14% in the comparator group. That is roughly 3 times the incidence. DKA is life-threatening. Why is this happening? It's likely because the delivery is variable. If you cough during inhalation, or if you don't breathe deep enough, or if the powder clumps because it was cold, you don't get your dose, but you think you did. With a needle, you see the plunger go down. You have visual confirmation. With powder, it's invisible. That ambiguity can lead to a skipped dose, which directly leads to DKA.
The DKA risk is certainly the most critical management point, I won't deny that. The label recommends monitoring, especially during illness or stress. But DKA often happens in the real world when patients simply omit doses because they are just tired of injecting. If Afrezza helps them take the dose in the first place, it might actually prevent DKA in the non-compliant population. The key here is patient education on the instructions for use, ensuring they inhale deeply and hold their breath as directed. If the technique is mastered, the delivery is reliable. It's entirely about training.
I want to zoom out a bit. We are talking about inhalers, and I think there is a dangerous ambiguity in how the public perceives that word. We usually associate inhalers with treating the lungs, opening airways during an asthma attack.
Right. Like albuterol or the newly FDA-approved Brensipirol for bronchiectasis. Those drugs are designed to stay in the lung and treat the tissue directly.
Exactly. But Afrezza is using the lung merely as a doorway to the bloodstream. It's a systemic delivery system. This confusion can be fatal. We looked at the fatal fluid source material regarding the death of Bruce Lee in 1973. It's a perfect historical example of this misconception. Lee died of cerebral edema, brain swelling. The modern theory is hyponatremia or water intoxication.
Yes, kidney dysfunction leading to fluid retention.
Now imagine if someone in that scenario thought, he's in respiratory distress, give him an inhaler. A standard asthma inhaler treats bronchospasm. It does nothing for brain swelling, it does nothing for fluid balance, and if we apply the Afrezza logic, if Bruce Lee had been diabetic and someone administered Afrezza, it could have been disastrous. We know he had potential kidney issues and fluid retention. The Afrezza label warns about fluid retention and heart failure, particularly with concomitant use of TZDs. But more importantly, if he had any underlying airway reactivity, Afrezza could have triggered a spasm right on top of his distress.
I agree. And that analogy highlights that inhaler is just a delivery method, not a drug class. It's like saying injection. You can inject adrenaline or you can inject poison. They do completely different things. If Bruce Lee had hyponatremia, he needed saline and diuretics, not a puff of anything. But this actually reinforces my point about the rigor of the Afrezza protocol. It isn't a rescue inhaler. You don't take it when you are collapsing. It's a maintenance therapy that requires a specific physiological profile, specifically healthy lungs, to be safe. The existence of misuse potential doesn't negate the value of the correct use.
But it does highlight the narrowness of the correct use. And that is where I struggle with the liberation narrative. The prerequisites for using Afrezza safely are incredibly high. You need healthy lungs, you need to be a non-smoker, you need to not have asthma or COPD, you need to have good spirometry results, you need to master a specific inhalation technique so you don't underdose and hit DKA. That is a very narrow therapeutic window. It's not just throwing away the needle, it's accepting a complex set of pulmonary risks and operational constraints.
At work, that window is a lifeline. Even if it requires a spirometry test once a year, that is a very small price for the daily freedom of eating a meal like a normal human being. The Technosphere technology allows them to treat a serious metabolic disease with a breath. That psychological benefit translates to better adherence, and we know that better adherence is the only thing that saves eyes and kidneys in the long run.
That is a compelling emotional argument, but I am stuck on the physical reality. Adherence might drop when 27% of them start coughing. Adherence might drop when they realize they can't use the cartridge instantly out of the fridge. Adherence might drop when they fear, rightly or wrongly, that they are damaging their lungs. It is fascinating technology, but I view the lung as a sacred organ for gas exchange.
It is delicate. It is our primary interface with the atmosphere. Turning it into a drug delivery port for a lifetime of chronic therapy is a gamble I am very hesitant to endorse.
We may have to agree to disagree on the philosophy of the lung's utility. You see it as a sanctuary. I see it as an underutilized pathway that can spare patients pain. Both are valid interpretations of the same FDA data.
Indeed. And the data is there for everyone to read. The black box is printed in bold for a reason.
So as we wrap up, let's summarize where we stand. For me, Afrezza represents a critical option for the specific patient who fits the profile. If you are a non-smoker with healthy lungs and the daily injections are destroying your quality of life, this device offers a rapid-acting, needle-free alternative that mimics the body's natural insulin spike. The screening protocols are the safety net.
And for me, the exclusions define the drug. The contraindications for asthma and COPD, the warning on lung function decline, the risk of DKA, and the high incidence of cough make this a niche product with a heavy safety burden. You are trading a known, safe delivery method, subcutaneous injection, for one that carries unique and potentially serious respiratory risks. The no needles headline is attractive, but healthy lungs is the non-negotiable price of admission.
It is a debate between the comfort of the delivery and the certainty of the mechanism. We encourage you to look at the instructions for use diagrams and the full prescribing information, especially the box warning in the source material to make up your own mind.
Absolutely. Understanding the difference between a rescue inhaler, a therapeutic inhaler, and a systemic delivery system like Afrezza is vital for patient safety. There's definitely more to explore in the material.
Thank you for listening to the debate. We hope this exchange has illuminated the nuances of inhaled insulin.
Until next time.